Okay, welcome dear friends. We have seen the first part of acute coronary syndromes, and this is the presentation on the second part of acute coronary syndromes, wherein we are going to deal with ST segment elevation myocardial infarction, or the transmural through and through more fatal and then challenging myocardial infarction. That will be the topic of this particular presentation. In this presentation, we are going to see an outline of what is the presentation of STEMI, how we have to make a diagnosis, what will be the risk stratification methodologies, and how we will trace the patient for early reperfusion. This requires thorough understanding, and let us see in the subsequent slides. As earlier, this is the floor plan of my talk. As you have seen in the first section, we have covered the first 6 aspects of the presentation up to here. In this presentation, we are going to look at STEMI, its presentation and management and risk stratification, and some interesting ECGs of acute coronary syndromes, and of course some messages related to prevention of heart attacks and prevention of acute coronary events and prevention of cardiometabolic and vascular events. As in the case of STEMI, the diagnosis mainly rests on history and physical, ECG monitoring, troponin tests. If the troponin tests are negative to start with, we have to repeat. Remember, ECG may be normal in the very initial stages of MI, and then we may require to monitor the patient. If monitoring is not available, serial ECGs may be taken to look at the ongoing dynamic changes in the ECG. Troponin test, if it is initially negative, should be repeated in another 6 to 8 hours time. When we make a diagnosis of myocardial infarction or ST segment elevation MI, we need to put up the following diagnosis. First thing is, we have to say this is a STEMI. That is ST segment elevation myocardial infarction, and whether the patient is eligible or not eligible for lysis depending on the contraindications and indications and the presentation of the patient and the duration of the pain to the doctor seeing the patient. Second thing is, we have to classify the infarction, whether it is anterior wall or posterior wall or inferior wall, a lateral wall or anterolateral, or a combination of these things. Then of course, we have to say whether it is a complicated myocardial infarction or it is a simple case of STEMI, in which there may be papillary muscle dysfunction, there may be mitral regurgitation, there may be ventricular septal defect, there may be heart failure, there may be cardiogenic shock, whatever may be, there may be arrhythmias, whatever may be the complication also has to be listed. So the diagnosis goes this way: ST segment elevation myocardial infarction, eligible for lysis, anterior wall infarction, there are no complications, or there are the following complications. Then the person who reads the diagnosis will understand what exactly is going on and what should be done for the patient. Always consider PCI, percutaneous intervention, percutaneous coronary intervention, as the most important treatment, because reperfusion is a must. If it is not feasible to do a PCI immediately, if the patient is not suitable for PCI due to various reasons which we are going to discuss, then of course thrombolysis is the other option to reperfuse the patient. So whatever may be the method of reperfusion, reperfusion is an important strategy for the management of STEMI. Fundamentally, it could be PCI. If PCI is not feasible or not available, or patient cannot afford it, or there are contraindications for PCI, then we should look at thrombolysis as an important option, and we are going to see what are the thrombolytic agents which we are going to use. This slide recommends the timeline for ESCS. I know it is very difficult to do these things in such a fast manner, but this is what is internationally recommended. Symptom onset to emergency medical service 5 minutes. Which of our patients in 5 minutes they will see a doctor? Is it are they available, or will they be able to contact the emergency medical service in 5 minutes? It's not possible, but this is a very crucial step where we need to educate the patients about the symptoms and presentation of STEMI and NSTEMI, and then so that they will be able to contact the emergency medical services for help as early as possible. Once the patient arrives at the emergency medical service, then 10 minutes time to reach, take the patient up to the ER or emergency room. So in 15 minutes time after the onset of symptoms, patient should have been ideally brought to the ER or emergency room, we call emergency department, ED. Arrival at ER, and then immediately in 10 minutes time we have to do quick physical and history taking and an ECG recording. So this is feasible. If the patient comes to the emergency room, then in 10 minutes we can have a quick look at the patient and get the history about the pain. You can look at the hemodynamic status and the cardiac function and the risk, and also look at the complications if any, and quickly record a 12-lead ECG. And if the 12-lead ECG is suggestive or is normal or is suggestive of right ventricular or inferior infarct, we require to do a recording of the right sided leads also. So after the ECG is recorded, then we classify the patient according to what we have seen in the previous presentation as NSTEMI or STEMI or unstable angina. Supposing the patient has got classical ST elevation myocardial infarction in 2 or more of the leads, contiguous leads, then he is a candidate for reperfusion or recanalization or revascularization. All these mean the same, opening up of the occluded artery. So the options then are 2. Within 90 minutes, if we can do the PCI, that is the best option. Supposing the patient cannot afford, or if we cannot transport the patient to a PCI center within 90 minutes time, then thrombolysis will be the option, and to complete the thrombolysis or start the thrombolysis within the next 30 minutes. So we have about 5 plus 10 15 plus 10 25, 25 plus another 10 minutes to decide on the procedure, 35, and another 30 minutes probably to organize thrombolysis, or 90 minutes to organize PCI. This is the timeline that we are supposed to follow. It is difficult, I know, to do these things at such a rapid pace, but if we have a system that is geared up and a protocol is laid up clearly, then once the patient arrives, at least we can see that the delay is minimized. But the delay at this level and at this level is not in our hands. It is in the hands of the transport by the EMS to ER and of the patient to seek the help of the EMS. But of course, from here on, the delay can be reduced as much as possible. This slide in a way summarizes the evolution of ECG changes in a case of acute myocardial infarction. Look at these figures from A, B, C, D, E and F. The figure A here is a typical normal QRS complex and T wave. Normal ST and T waves and normal QRS complex. This will be given way immediately in the first few minutes to 1 hour. ST segments are mildly elevated and prominent T waves will appear. This is called hyperacute T waves or peak T waves. So we need to look at these T waves very carefully, because this is a very early sign of infarct. Then the C is marked elevation of the ST segment, as can be seen here, with still upright T waves merging with the ST segment elevation. And then the next step would be ST segment continues to be still elevated and T waves becoming cup shaped and inverted, and probably a small Q also starts, and this is an evolved infarct to some extent. Then of course, in this figure you can see the Q is well formed, the ST segment has come down almost to the baseline, and there is a symmetric deep T inversion. Deep Q waves, ST segment returning to baseline, and deep inverted symmetric T waves. And of course, finally when the patient recovers from the acute attack of infarct, then ST segments become normal and the Q waves may still remain as a sort of rudimentary thing, as an indication of previous MI, and the T waves have returned to normal. So these are the changes, ECG changes of evolution in a case of myocardial infarction. This ECG tracing is in lead 1. Normally, lead 1 will show a small Q wave. This is formed because of the septal activation. The septum is activated from left to the right. So much so the wave of electrical current is moving away from the left-sided lead. Lead V1 being a left-sided lead, L1 being a left-sided lead. The current going away from that will produce a small negative deflection, which is called normal non-pathological Q wave. Then that will be followed by a positive current towards the lead, which is the QRS, this is the R wave, and then of course the ST segment, which is isoelectric, and the T wave. This is a normal recording, and these Q waves should not be confused with pathological Q waves. Then what is a pathological Q? That we will see in the subsequent slides. So before we look at the pathological Q waves, how do we define a normal Q wave? Normal Q wave in lead 1 is due to the septal depolarization, which I have already explained to you. It is small in amplitude, less than 25% of the succeeding R wave, or less than 3 millimeters in depth. Its duration is less than 1 small square, which is equal to 0.04 seconds. It is seen in lead 1 and sometimes may be seen in lead V5 and V6. Here is the depiction of what is a pathological Q wave. Again, it is in lead 1. Lead 1 is the lateral lead or left-sided lead, and you see here the colored areas. The gray area is called zone of injury. The second zone is called zone of ischemia, and the dark black zone is called zone of infarct. So zone of infarction, zone of ischemia, and zone of injury. It is the zone of infarct that causes the Q waves because there is an unopposed action, an unopposed electrical current away from the lead 1 because the muscle mass here is lost. There is no electricity going on here, and there is almost like an electrical hole here, and that produces deep Q waves in lead 1. Zone of ischemia produces what are called the ST segment changes, and zone of injury produces changes in the T waves. So these are three classical zones. Even in an infarcted area, the entire myocardium is not infarcted. The central part, which is totally devoid of blood supply, is infarcted, and that will throw the Q waves. The adjoining area is zone of ischemia, which is responsible for the ST segment changes, and then of course the zone of injury, due to the lack of blood supply, partial lack of blood supply, it reflects, it's reflected in the T waves. So the abnormal QRS vector is going this side in the initial part, and that produces a negative, deep, wide infarct Q wave in lead 1, sometimes can be seen in lead V5 and V6 also. So then what is the pathological Q wave? Pathological Q wave of the infarction in the respective leads is due to the dead muscle. It is deep in amplitude, more than 25% of the succeeding R wave, or more than 4 millimeters in length. Its duration is more than 0.04. Remember, the non-pathological Q wave is less than 0.04, and here the pathological Q is always more than 0.04 in its duration. It is seen in the leads facing the infarcted muscle. If it is the left-sided muscle, left lateral wall, then it will be in L1, V5, V6, and if it is an inferior wall, it will be in inferior leads L3, AVF, and L2. These are due to loss of electrical activity in the infarcted muscle area. This again depicts the serial ECG changes in a case of myocardial infarction. Before coronary occlusion, normal P waves, normal small Qs, and then this is QRS, ST segment is in the baseline, and normal T waves. Once there is an onset of infarct, the first several hours, then R wave may be normal or nearly normal, or the amplitude may be reduced. ST segment elevation and tall peak T waves will be seen. Then on the first day, the R wave amplitude slowly starts diminishing, Q waves start appearing, ST elevation, T waves are getting flatter. Then in the first and second days, after the first and second days, R wave is gone or nearly gone, and very little R wave, deep, significant, wide, then amplitude more than 4 millimeters, Q waves, ST elevation still continuing but decreasing, T waves start getting inverted and cup shaped. After 2 or 3 days, there are no R waves seen, marked deep Q waves, ST segment return to the baseline, deep T inversions are the rule. Then after several weeks or 1 or 2 months after the infarct, some R wave may appear because some part of the myocardial activity has come back, and then significant Q waves will remain almost in some patients for lifetime, for a long time in other patients. T waves continue to be often inverted. ST segment elevation may occur if there is an aneurysm, otherwise ST segment will be in the baseline. In a recovering patient, if there is an ST segment elevation without any pain, it is significant that the patient is going for aneurysm in the infarcted area.